our next presentation is on bronchial lung valve reduction. It's going to be presented by Dr. Boyd Hehn. And Dr. Hehn is our Chief of Pulmonary and Critical Care Medicine at Guthrie. And he has extensive experience with this and many other things. He does fellowship at the National Institutes of Health in Bethesda, Maryland, Johns Hopkins University for Pulmonary and Critical Care, residency at Presbyterian Hospital in New York. He's board certified in critical care medicine and pulmonary disease, and he went to Columbia University. And it's my pleasure to introduce Dr. Hehn.
Tom, thank you so much. So right now I've got my the presenter view up, so I can't see if it's actually coming across. So if somebody could let me know whether or not my slides are working, that'd be great.
It is not yet. Have you, down to the bottom, does it say share screen in a little green box?
How's that?
There, we see it now.
All right, so bear with me 1 second because I need my other screen to come back. There we go. All right. So, and I'll have to remember to stop sharing at the end. So hello, everyone. I'm Boyd Hehn. I'm the new Chief of Pulmonary and Critical Care Medicine at Guthrie Health. And it's my pleasure to be here today because I've been asked to talk about a topic that's near and dear to me, which is bronchoscopic lung volume reduction. So the objectives, we're briefly going to touch on the physiology of air trapping in emphysema and why this is important for patients' symptoms. We'll talk about how lung volume reduction, we're going to go back to surgical lung volume reduction, alters pulmonary mechanics and lets patients breathe better. I'll go through selection criteria for bronchoscopic lung volume reduction, the contraindications, collateral ventilation. What is it and why is it a contraindication to bronchoscopic lung volume reduction? And finally, this is just my personal opinion, pulmonary rehab and lung volume reduction are a match that is made in heaven. So we do this a little different than was done in the net. We do ours after rather than before. But somebody, you'll see why it's important that somebody who goes through this actually then does the pulmonary rehab so they benefit from the valves that were placed. So kind of the physiology. Your emphysematic patient, they're okay at rest, but why are they breathless with exertion? The mechanics really don't change. So we have to go back to what is airflow obstruction. So COPD is defined as an FEV1 FVC less than 0.7 by Gold criteria. And what you have to remember is as FEV1 declines, actually this group probably doesn't have to remember, they know, as FEV1 declines, airflow limitation worsens. And this is, what we're talking about is flow, which is volume over time. So the best predictor of breathlessness or dyspnea is the presence of resting and dynamic hyperinflation. So basically the RVTLC off of body plethysmography gives me the best idea of is my patient going to be more breathless with exertion or not? So I'm going to do something that we really can't or we shouldn't do. And I'm going to take us into the respiratory duty cycle. So this is, length of breath from start to finish. So number of breaths divided into 60 seconds, okay? And what I'm going to do is I'm going to fix us at an IDE of 1 to 2 and show you what happens. So at a rate of 20 with the respiratory duty cycle of 3 seconds, 1 to 2 would give us 1 in and 2 out. We cut that rate to 10, and now we have a 6-second duration. And here's where this would get difficult. You have a 2-second inhalation, but a 4-second exhalation. So what you see is as patients breathe faster, which is what we do with exertion, expiratory time disproportionately shortens. And so if you have airflow limitation, you start to breath stack, dynamic hyperinflation, auto PEEP on a vent. And the way to think about it, if you're not vented, is that as you breathe faster and faster, and these patients are profoundly airflow limited, you run out of inspiratory capacity. You basically run out of room to breathe, and this is why these patients become so symptomatic. It also explains why somebody who may have significant obstruction but does not air trap tends to be less symptomatic than somebody with significant air trapping. So why does lung volume reduction work? Okay, and what it really comes down to is by reducing the size of the lung, of the hyperinflated lung, we're basically improving diaphragm shape characteristics into a more advantageous form. So, you know, a patient who's hyperinflated in air traps will have flattened diaphragms rather than the beautiful C diaphragm that we all like to have. And so we can try and convert them back towards that so that the diaphragm actually is in a more advantageous position. And the other thing is the reduction in residual volume basically gives you more room to breathe. As you reduce residual volume, the inspiratory capacity should improve. And there really are two options. The first is surgical lung volume reduction, and the most recent is bronchoscopic. So we're going to go back to the NET trial, okay? And this is, by the way, I think the only trial of surgery versus medical therapy in patients who were randomized. It was done from January of 98 through December of 2002. All patients with pulmonary rehab after meeting entry criteria, and then were randomized to surgical lung volume versus medical therapy. The original estimate, okay, they wanted to accrue 2,500 people. However, they had to be completed by December 2002. So they evaluated almost 4,000, but they only enrolled 1,218. So they were about a little under half of the estimated accrual, okay? And so these patients were enrolled and randomized. Of these, 608 underwent surgical lung volume reduction, 610 medical therapy. And medical therapy, just remember, 1998 to 2002 was essentially duoneb. The surgical technique in the NET was bilateral stapled wedge resection. This could either be done by median sternotomy or bilateral video-assisted thoracoscopy. And the goal was to resect 20 to 35% of each lung, targeting the most diseased portions. When you look at compliance, okay, so remember, patients met criteria based on their pulmonary functions, did pulmonary rehab, and then they were randomized. Okay, so there was no surgical evaluation pre. So of the 608 patients assigned to surgery, 580 did undergo surgery, 21 declined, and 7 were deemed medically inoperable. 70% underwent bilateral LVR by median sternotomy, 30% bilateral VATS. Just to kind of give you an idea of the long term, 4 of the patients who underwent surgical LVR then underwent lung transplantation post lung volume reduction. In the medical therapy arm of the 610 assigned to medical therapy, 33, so 5% had LVR outside of the clinical trial. And I believe most of those were done at Penn, where Joel Cooper was at the time. 15 patients, so 7.5, underwent lung transplant during the trial. And here's the concern of LVR. Okay, so it is post-surgical mortality. So the 90-day mortality for surgical LVR was 7.9%, and there was no difference depending on surgical technique. So sternotomy's mortality equaled VATS mortality. In the medical therapy arm, mortality was 1.3% in the 90 days after randomization. When you look at the overall study period mortality, there is no difference in overall mortality between surgical and medical groups. 157 of the LVR patients died, 160 of the medical therapy patients died. And what this does is it gives you a total mortality rate of 0.11 death per person years for both groups. So we see early surgical mortality, but by the end of the trial, there's no difference in overall mortality. So what were the associated factors with high-risk patients? Well, if your FEV1 was less than 20% of predicted, diffusing capacity less than 20%, or you had homogeneous emphysema. So if you look at panel A, because my pointer doesn't actually work on this, what you'll see is there's no difference overall, other than that you see that early mortality, but by the end of the trial, post-randomization, there's really no difference medical surgical mortality. When you look at high-risk patients in panel B, what you see is that you have a significant increase in early mortality post-op and that the curves never come back together. So even by the end of the trial, high-risk patients who had surgery still had a higher mortality, although medical therapy is approaching them, than the medical therapy group. In panel C, non-high-risk patients, what you'll see is that the probability of death basically mirrors each other. There may be a trend towards surgery being less, but it really statistically is not different. And then we get into the exercise capacity. So if you have upper lobe predominant emphysema with a low baseline exercise capacity, what you see is that medical therapy was associated with a significant increase in the probability of death than having a surgical lung volume reduction performed. Okay, if you have upper lobe predominance, panel E, high baseline exercise capacity, there's no mortality benefit. There's also no mortality increase in risk. Non-upper lobe predominance, so more of a homogeneous emphysema, low baseline exercise capacity. Again, what you see is there's really no difference. But you have in panel G, non-upper lobe predominance, high exercise capacity. This is just the opposite of the upper lobe. Patients who had surgery had a lower risk of mortality than patients under medical therapy. So what we do is we wind up with two groups here. You have upper lobe disease, low exercise capacity at baseline. There is a mortality benefit to having surgical LVR. And if you have non-upper lobe predominant disease and you actually have preserved baseline exercise capacity, again, there's a benefit to having surgical lung volume reduction. So what happened is after 2002, what kind of came out of this is patients who had surgical LVR, particularly upper lobe predominant, low baseline exercise capacity, those patients, their mortality improved, their functional status did improve, but it's at the trade-off of this elevated short-term mortality. And so surgical LVR kind of falls by the side. So in a 20-year career now, I've probably referred 10 patients for surgical lung volume reduction. About half have had it done. And that may make me actually a relatively high referrer. So the next thing is, and this is about the same time, my reference is in the corner, but it's under my screen. So this is 2005. We now see the first look at bronchoscopic lung volume reduction. And this was just kind of a proof of concept study. So this is the effect of bronchoscopic LVR on dynamic hyperinflation and exercise and emphysema. So the idea is, well, maybe if we don't operate on people, maybe if we can just do an endoscopic procedure, we won't see that increase in mortality up front. It will be reversible, and maybe we have an option to improve the quality of our patients' lives. So 19 patients underwent lung volume reduction with valves, and they're using an emphasis valve, which no longer exists, at least in this country. I don't know if it's still used worldwide. Two of the patients post-valve developed epiglottal pneumothoraces. And here's the big thing. Only 5 of 19 patients developed radiographic atelectasis. So when you look at the outcome, 39%, there was a 39% improvement in mean cycle endurance time. So this is basically, you get a cardiopulmonary exercise stress test. We determine what 80% of your maximum VO2 is, and then we bring you back and you do a baseline endurance time at about 80% of your maximum workloads. Okay, and that's about 227 seconds of exercise. 39% improved, there was a 39% improvement in the mean cycle endurance time to 315 seconds post valves. And improvement was associated with an improvement in lung function. But when you look down at the next one, atelectasis is what significantly was associated with an improved exercise capacity. So here you're going to see the change from baseline. So if you had atelectasis, and it's only 5 people, so the confidence intervals are really wide. What you see is they had about a 225-second improvement, plus or minus 221. Whereas if you didn't have atelectasis, you had about a 40-second improvement, plus or minus almost 2 minutes. So this is the first one. We then get to believer hi-fi. So notice that we're now 2015, so we're about a decade in. Believer Hi-Fi was a single center trial. It was a double blind, but it is sham controlled. So everybody underwent bronchoscopy, whether or not valves were placed, and they were randomized in a 1-to-1 fashion to valve or no valve. And the lung characteristics had to be heterogeneous emphysema, and by CT, you had to have an intact interlobular fissure. The PFT requirements, FEV1 less than 50% are predicted, so these patients would have severe disease. Total lung capacity at least 100, and residual volume greater than 150. So this is the same criteria as what they were using for surgical LVR. And then they're using a 6-minute walk distance of less than 450 meters so that they get rid of any high-performing individuals. And notice that their Modified Medical Research Council dyspnea score is 3 or more. And just to put it in perspective, 3 is I'm out of breath walking 100 meters, or I have to stop after walking a few minutes on the level. 4 would be I'm out of breath getting dressed, or I'm too breathless to leave the house. So the outcome, they had 50 patients, mean FEV1 of about 32%. So a pretty respectable severe emphysema group. And when you look at the change in FEV1, the mean change was for valves, there was about a 25% improvement in the FEV1, whereas those who underwent sham had probably a non-significant 4% decline. Median change is the important thing. So if you had the median change in FEV1 was about 9% if you had valves that were improved, whereas shams went down by about 3%. So what you're seeing here is even with CT, there may be a patient or a fissure selection because people who had the big improvement probably had complete fissures. That's why there were people without complete fissures who didn't have as much improvement. There were 2 deaths associated with endobronchial valves. None were considered procedural related. And it's interesting that the one prolonged pneumothorax was in a sham patient. So here's where we now get to the approval. So it's the IMPACT trial. So this is 93 patients, baseline characteristics, FEV1 of 29%, plus or minus 6.5, residual volume. Look at this, 275%. That is profound air trapping. So you're probably, with me not having data on their TLC, just to put it back, you're probably talking at least 65, if not beyond 70% RV-TLC ratios. They were randomized almost 1-to-1 to lung volume reduction 43, standard of care, so medical therapy 50. And now we get into what's called Chartis. So Chartis is a high sensitivity pneumotac on an endobronchial catheter with a balloon attached. So imagine taking a pulmonary artery catheter, putting it through your bronchoscope, occluding the lobe of interest, and sometimes you occlude the alternate for procedural reasons. And what you're doing is once you occlude, you sit there and you wait to see airflow cessation. If airflow cessation occurs, it suggests that the fissure is intact, and then patients will benefit from a valve, okay? So all patients done here actually underwent bronchoscopy. All were confirmed by Chartis to be collateral ventilation negative, and then they were randomized either to valves or standard of care. If you look at the 3-month outcomes, there's an improvement in FEV1 by about 13%, plus or minus, I love the error bars of 28%, whereas the standard of care, again, non-significant decline of 3%, plus or minus 13. We now start seeing the post-procedural pneumothorax rate, and this is related to as the lung changes shape, you're going to be at risk of having the lung tear. It's actually not a procedural risk, it's a lung change risk where the lungs tear and then you wind up with a pneumothorax, and 25-30% is about appropriate. So when you look at, for the intention to treat population, FEV1, what you see is, again, we're probably 13 to 15% improvement. and this is percent change from baseline in FEV1 here versus in the standard of care arm, which is the square. What you're seeing is about no significant change, but notice small numbers, so your error bars are big. When you look at the per protocol, again, it's about the same. You're looking at 6-minute walk distance, so other measures, okay? What you see is about a 25-meter improvement in patients from baseline with, and they're a 6-minute walk distance, 3 months post valves, whereas there's a 20-meter decline. So you're seeing about a 40-meter difference. And, this is not, this is not like pulmonary hypertension. However, in pulmonary hypertension, we use the difference in 6-meter walk distance to look at the benefit over the population. And this is about on average with the medications used for PH, that 40-meter distance. When you look at their St. George's respiratory questionnaire score, okay, and a decline of, I believe 4 is considered significant, 4 points. What you see is a near 10-point decline in patients with valves versus no substantial difference in patients who did not get valves. Now, some of these error bars here some of the patients just being in a clinical trial will make a difference. And the difference in residual volume, again, you see some pretty substantials out towards 2 liters, but it's about a 480 milliliter change, 0.48 liter change in residual volume valves versus standard of care at 3 months. So we saw a signal here, and that led to the LIBERATE trial. So LIBERATE, patients 40 to 75 with COPD, the PFT requirements are here, FEV1 15 to 45% of predicted, total lung capacity at least 100%, residual volume 175% or more. And a diffusing capacity, again, had to be greater than 20%. Now, that is from the surgical LVR literature, which said diffusing capacity under 20% was associated with an increase in mortality. So those patients aren't being retrialed. 6-minute walk distance, they don't want low performers, so it's 100 meters minimum. And if you're above 500 meters, you were considered a high performer. They did not want to put valves in. So now we are using what is called STRATIC. So you're looking at target lobe destruction score. So this is Hounsfield units, okay? So the idea is a normal lung has a certain density because lungs are just airbags. So the density tends to be low because you've got air plus the normal structure of the lung. As emphysema worsens, okay, your Hounsfield units go down. So they average out the lobe. And what they were looking for was a target lobe destruction score greater than 50%, but they wanted an absolute difference of greater than 14% between the target and non-target ipsilateral lobe. Okay, so you want to pick the worst lobe, not necessarily the biggest lobe. All patients underwent Chartis assessment for fissure integrity. All patients were, all patients to be included had to be CV negative, and all CV negative patients underwent randomization in a 2-to-1 fashion, valves versus standard of care. So there were 190 patients, 128 wound up with valves, 62 randomized to standard of care, and we're now looking at 1-year outcomes. Okay, and what was considered a significant improvement in FEV1 that was meaningful for the FDA was roughly 15%. So the 12-month outcome is 47%, almost 48% of patients had a greater than 14% improvement. So they met the criteria in FEV1 from baseline, whereas standard of care only about 17% met the same criteria. So again, this is just graphically, you're almost seeing half the patients who got valves improve versus very few people in the standard of care arm. When you look at FEV1 change from baseline again versus controls, okay, this is just, overall valves, what you're seeing is on average about 110 cc improvement. 6-minute walk distance, again, you improve about 15, whereas the control group lost about 25. And the St. George's Respiratory Questionnaire, again, patients with valves improved significantly versus no change in the standard of care arm. And I'm just going to, again, when you look at responders, about 50%, again, FEV1 greater than or equal to 15%. When you look at a 12%, what we would consider a bronchodilator response, it improves about 56. Residual volume, okay, as far as improvement, this would be greater than a 310 cc improvement. Almost 2/3 achieved that, okay. Improvement in your St. George's questionnaire, about half got better versus 30% here. Bodie index, look, if you're moving the Bodie index, that's a pretty significant improvement. That's quite meaningful because it does have some impact on mortality. And again, total lung volume reduction greater than a 350 cc improvement, so a decline. Again, majority of patients who had valves hit that. And this is the one thing that you have to, the one sobering thing. And I'm just going to focus on panel A, the FEV1 responders. So again, you have a group that got better. You have another group, no better, no worse. Notice you're probably about 15% of patients who got valves, just like in the standard of care arm, their FEV1 actually declines. So there's a group that gets worse. And this kind of mirrors what we're seeing in clinical practice. So what are the criteria for lung volume reduction? Okay, so we actually have gone back to using surgical LVR criteria, slightly modified. So you have to have COPD, your FEV1 is 15 to 45% of predicted. For patients with profound air trapping, we will go up as high as 50%, but the majority of patients have to be in that 15 to 45%. Total lung capacity has to be 100% minimum, okay? Residual volume greater than 150 or greater. What I will tell you is my personal, the higher the residual volume percent predicted, the more likely the patient is to have meaningful clinical improvement. So while we will look at 150, patients who are 200, 225 or higher percent predicted residual volumes, those patients tend to have a better physiologic response. Diffusing capacity has to be better than 20. And again, 6-minute walk distance, it has to be 100 to 500. We get a room air blood gas, even if they're on supplemental oxygen. Maximum supplemental oxygen that I will do is 4 liters continuous flow. The PCO2 has to be less than 56. If it's higher than that, patients are referred for non-invasive positive pressure ventilation, have to demonstrate compliance, and only if they have an improvement in their PCO2 to less than 56 would I then consider them for LVR. The PO2 has to be greater than 44 on room air. If you're below this, your risk of mortality is excessive. In the trial, BMI had to be less than 32 because we're not operating on people. Again, good candidates I will look at under 35, okay? They have to be an ex-smoker for at least 4 months. And if you are an ex-smoker in this period of time, I will consider doing urinary nicotine metabolites to make sure you're really an ex-smoker. And then here's the hard one: no prior lobectomy or more than a prior lobectomy. So theoretically, any thoracic surgery may put that particular side at risk. So yesterday I saw a patient who meets criteria. She had 2 wedge resections on the right. So she doesn't necessarily have the lobectomy, but that right lung, because it's been operated on with 2 wedge resections, probably has scar. I think her risk of a pneumothorax on that side would be higher. And so I would consider her, but for a single side only. The procedure, if you meet the criteria, let me go back here for a second. So once we've done all of this and you check out, everybody gets an echocardiogram, because if you have pulmonary hypertension, your mortality risk is high. So if an echo suggests, I send people for right heart catheterization to make sure that they don't have more than moderate pulmonary hypertension. mild, I don't think is a big issue. I would have to look at your hemodynamics to make an assessment if you were in that moderate range. And the last one is we do get either a quantitative perfusion scan so that I can match target lobe with poor perfusion. If I have more than one target, so I'll pick the worst perfusion. And here at Guthrie, we have 2 CT scanners that do CT SPECT. And so I'm going to be actually looking at using CT SPECT for blood flow. So instead of zones, I actually just match it up to lobes, which I think would be a better thing. The procedure itself is done under general anesthesia. I only use the Zephyr system. I am not doing lung volume reduction with the spiration system. I've used the spiration valve since 2008 for medical management of bronchopleural fistulas. The reason why I am using Zephyr over the alternate has to do, I firmly believe that knowing their collateral ventilation is paramount to doing the procedure and not having poor patient selection. So that is why it has nothing to do with the valve itself. They do not do Chartis with the spiration valve. So everybody, once you're put to sleep, you get your basic bronchoscopy, make sure there's nothing of concern in the airway that we need to do something about. If you pass that, we go to the target lobe, particularly if it's an upper, and we do the Chartis. If you have a lower lobe target, oftentimes you want to use the upper because the lower lobes will actually have bronchial collapse early on, and you get a false get a false positive collateral ventilation negative. If patients are CV negative, we proceed with valve placement. If they are collateral ventilation positive, the procedure is aborted. The patient is awoken and they're discharged that day. There is an interesting concept called a low flow state. So this would be, we wind up with 6% airflow, and we can't tell if it's just a lobe that's going to take forever to stop airflow, or if there may be there may be some, the fissure may not be complete. It's difficult to tell. And at that point, it's operator decision about whether placing valves or not. The procedure afterwards is relatively simple. We actually use the introducers for sizing. They come in a 4 and a 5 millimeter introducer. There is a J introducer, at least in the 4. And you have these little wings, and it has to be, little wings don't touch, big wings should touch in order to make sure you have the appropriate size. And valves come in a 4 low profile, which actually gives you a 25% improvement in diameter, a 5 and a 5.5. And the 5 does come in a low profile. 5.5 I don't believe is a low profile yet. Occasionally you do have to place upper and middle on the right. Take out both because the minor fissure may not be complete, and that's allowable. Once patients have the procedure done, they are admitted for 72 hours on average. This is a picture of what a Zephyr valve looks like. It is a nitinol stent with a silicone cover and this little like lips in the middle. It's a little duck bill. That's the vent. And so what we actually look for after we place them is we want to see the valves venting, essentially breathing out, but not breathing in. The idea behind this is air can't go in, air can come out, secretions can come out. Complications is a 25 to 30% risk of pneumothorax. Majority are in the first 3 days. Now, just realize a patient with severe emphysema has a 3% per year non-additive risk of pneumothorax anyway. And the risk of pneumothorax returns to baseline 3% per year after 30 days. So when the trial was first done, they were actually doing it as a day-stay procedure. So patients were only held for 23 hours. Patients were sent home post. This was the holy grail of lung volume reduction. It's almost an outpatient procedure. And there were 2 deaths in the trial associated with pneumothoraces occurring afterwards at home. The trial was reconfigured, and once they then admitted people for 3 days, there was only 1 further death that was adjudicated to a pneumothorax, and it was because a patient came in late pneumothorax, and the ER physician put a trocard chest tube through the left ventricle. So they adjudicated that it was pneumothorax related when it was actually procedurally related. The other major risk is a need for revision. In the studies, it's about a 12.5% risk of revision. In clinical practice, it's 25 to 30%, and that actually may be conservative. So needing revisions is actually relatively common. So I'm going to take you through a patient and give you an idea how this works. So RR is one of my favorite patients. He's a 75-year-old gentleman, a retired letter carrier. Our connection is my grandmother was a postmistress. He's an ex-smoker for 2 years, and he has at least a 40-pack year history. When I met RR, a very proud man, he was unshaven because he basically is out of breath walking from his bedroom to the bathroom, which is not 20 feet away. He had been out of the house 6 times in the prior year, all for physician appointments. And basically, he is profoundly dyspneic. His dyspnea is so severe that he has prandial dyspnea. He is out of breath eating. He can no longer walk his dog around the block, and he can't perform his ADLs. His MMRC was 3, bordering on 4. The interesting thing is his COPD assessment test score is 9, so he's not exacerbating, he's just horribly symptomatic. Meds were noroalbuterol, and he was a little hypothyroid and levothyroxine. So this is his evaluation pulmonary functions. So his forced vital capacity was 51% of predicted. His FEV1 is 1.11, 32%. Ratio is 49%. His TLC, as you see, is 127% of predicted with an RV of 221%. So that gives him a ratio of 69. Diffusing capacity is actually relatively well preserved at 50%. He could walk 329 meters. He did need to stop. So that's respectable. So his symptoms are a little worse than I would expect for the distance he was able to walk. He did not require supplemental oxygen, and his blood gas does not demonstrate hypercarbia or profound hypoxemia. So this is what his StratX looks like. So rather than show you the CAT scan, I'm showing you what his StratX report looks like. So the key here on the right, so this is voxel density less than minus 910 Hounsfield units. That's really bad destruction. This kind of darker gray is, so that's greater than 70% density, less than, so there's very little non-destroyed lung left. This is 60 to 70%, so there's still not a lot of normal lung left. This light gray, which is up here in the right upper lobe, is 50 to 60%, and he has no normal, which is less than 50% voxel density, less than 910. The other thing you see here is fissure completeness. Dark bar is greater than a 95% estimated fissure completeness by their CT interpretation. This kind of lighter gray bar, which you see here in minor fissure between the upper and middle, is 80 to 95% completeness, and he has no dotted lines, which would be less than 80%. So what does this mean? If we estimate that you have less than 80% fissure completeness, there's no way that you are complete, and we just stop right there. If you're in the 80 to 95% fissure completeness suggested by CT, it's 50-50. It's a coin toss. 50% of the time your fissure is complete, 50% of the time your fissure is not complete at StratX, or sorry, at Chartis. If you are in the greater than 95% fissure completeness, your risk of having an incomplete fissure is still 15%. And so this is why I think it's so important that you actually do an assessment of collateral ventilation. A 15% failure rate is roughly 1 in 6. So we then look down below under results, and what you're going to get is, and let me just, there we go. So what you see here is fissure completeness, percent voxel density less than 910, less than 950, telling you better lung. But we then get inspiratory volume. So they're estimating an inspiratory volume. So when you look here, he's got an excellent right lower lobe, suggests he's got a good fissure. The percentage of voxel density less than 910 or minus 910 is 73%. So he has very little normal lung there. And when you look at the inspiratory volume of that size, it is almost 2 liters. Now, the flip side is he also has 2 backups. Now, we don't see a huge difference, okay, between the 2 sides, upper and lower, but you could, with a left upper lobe of 1500, you would have I would consider this a backup lobe if this is not. I'd be a little worried about some post-op hypoxemia. So I'm going to take you through a couple others to show you what things look like. So this is no target lobe. So we have no significant, destruction. So this is somebody who has severe COPD, whose PFTs met criteria. And when you start looking for, do we have a target lobe? They've got reasonably good fissures, but they don't have enough lung destruction score. And this is somebody that I would turn down. Here's oftentimes what you also see, and this is a better demonstration. I've got a good lower lobe here with very little destruction. Okay, I have an upper lobe. So there's definitely more than a 14% difference between these two with the good fissure in between. You could use this as a backup. The upper and middle, you'd have to do both because there's an incomplete fissure between, or incomplete minor fissure. Okay, but you would have that greater than 14% difference here. But notice that you're also dealing with a fissure that has a 50-50 chance of being complete here. Here's targeting decisions. Okay, I've got a, so this is the majority of this is 60 to 70% of the voxels less than 9/10. In fact, 63%. I've got a good lower lobe. I've got an excellent fissure here. I've got a slightly better upper lobe, but a less damaged middle lobe. Good fissure, but that minor fissure is incomplete, meaning I'm going to have to take both. Notice that, again, both sides give you about a 2-liter inspiratory volume. So if I was looking at this patient, this is my primary target. If this fissure was incomplete, I can use these two as a backup, and I'm not losing that much on the middle. One thing I would get a little concerned about is as you approach an inspiratory volume of 3 liters, and this is just my own clinical experience, you start worrying that there's going to be such a significant difference in the lung shape post valve and atelectasis that I would worry that those patients at higher risk on this side of having a pneumothorax. So if I did the right, this person might actually stay for the full 5 days. So our initial candidacy, he meets criteria. His FEV1 is definitely in this range. Total lung capacity is appropriate. Residual volume was 220. Diffusing capacity was good, was preserved. I have a left upper lobe, left lower lobe, and a right lower lobe target, with the right lower lobe being the primary. Fissures are good, and he's on appropriate therapy. He has no suggestion of pulmonary hypertension, and his perfusion scan demonstrated 50-50 lung perfusion, but the right lower lobe had less than 10% perfusion. So at the end of the day, with Stratix, I've got 3 target lobes. With the perfusion scan, left side's definitely not as good. Right lower lobe is the one that he will miss least. So he comes in, gets general anesthesia, nothing endobronchially. He is collateral ventilation by Chartis negative in the right lower lobe, and he undergoes bronchoscopic lung volume reduction of the right lower lobe with 5 valves placed. And by the way, when you look at lobes done, left upper lobe is most common, followed by right upper, right middle, left lower lobe, and right lower lobes are the least common lung volume reductions. He spends 3 days in the hospital, daily x-ray, no pneumothorax. Other care requirements: first day, they cannot raise their arms above their clavicles, and everybody is on bed rest. Second day, out of bed to chair with commode privileges. Third day, they can walk to the bathroom and walk the halls. So he gets discharged. Everybody comes back in 2 weeks. And so now he walks in and he tells me that he's actually able to walk 2 blocks. I actually learned an interesting phrase, which is, I can now play my numbers. And I didn't know what that means. And apparently it means he's buying a scratch lottery ticket. So he's now walking to the bodega to pick up his lotto ticket. Chest x-ray demonstrated partial right lower lobe atelectasis, and that's what you want to see. You don't want to see early complete atelectasis because the risk of pneumothorax goes high. At this point, I okay him to pulmonary rehab where he becomes the star pupil. He gets a day 45 CAT scan and he has partial right lower lobe atelectasis. He has a 750 milliliter volume decrease on the post-op Stratix, and it turns out he had a migrated valve. So this is what you're seeing, and this is, I'm sorry I'm using these, it's just easier to show you on this, but there is a little leak here. I can't keep going to show you that there's a little airway uncovered. So this is what a post-Stratix looks like. So let me take you through this. So intermediate, segmental, subsegmental. So we didn't put anything in the bronchus intermedius or the right lower lobe bronchus, so it's not treated. RB6, so RB6 would be the superior segment. Again, nothing proximal superior segment of the right lower lobe, but he has a valve in RB6A and a valve in RB6B, both occluded. There's nothing present on C. RB7 is the medial segment, okay, and it's occluded by a proximal valve. RB8, and here's where what I saw and what they saw are different. They're saying is not treated. It had actually just migrated up. Okay, RB9 is, so that's the lateral segment occluded by a proximal valve, and RB10 occluded by a proximal valve. So notice baseline volume here in the right upper corner is 1900. Follow-up volume is 1100. So he's had about a 775% reduction despite it not being complete. So his total lung volume is down by about almost 40%. So we have to bring him back. He undergoes a redo bronchoscopic lung volume reduction. Again, he has to be put to sleep, intubated. Valve in RB8 was noted to be migrated, and I could see a subsegmental airway visible. Valve was explanted, and I just placed a slightly larger valve more proximally, covering the entire RB8. So now everything is covered. Spends 3 days, no pneumothorax, and he is discharged. So he completed pulmonary rehab. He was my star patient. I think I got more referrals out of pulmonary rehab because of him. So patients self-referred than I got from some of my referring physicians. Now he walks several blocks without stopping. He's back to walking his dog. He walks 2 blocks to pick up his lottery ticket. He walks 3 more blocks to pick up a sandwich at his favorite deli, and then he comes back home. He mows his yard with a weed whacker, tells me he does have to stop a number of times, but he can do it himself and doesn't need to ask his neighbor to do it. He rests and recovers quickly. His albuterol use, which was multiple times daily when I met him, is now less than daily. And his final post-Stratix. So what you see here, you see 1, 2, 3, 4 valves, okay? And this sliver right here is the entire right lower lobe. So what you're seeing is the right diaphragm is now pulled essentially high. You're looking at an upper and a middle, so he now has room to breathe. His post-treatment Stratix, he has complete lobar occlusion. He has lobar atelectasis. There's no volume in it. He is down by almost 2 liters. What's interesting is his total lung volume difference only 1 liter down. Okay, and that's because he has had commensurate increase in volume of the right middle and right upper lobes. There's even been a little change on the other side. Okay, so as things get smaller and there's more room, better lung does hyperinflate a little bit. But here's proof in the pudding. This is his post-pulmonary functions, okay? So this is pre on the left, post on the right. So his forced vital capacity went from 2.27 to 2.94 liters. So that would be considered a pretty good bronchodilator response. FEV1 went from 1.11 to 1.42 liters. Again, that would be considered a significant bronchodilator response. Notice that his obstructive index doesn't change. This is one thing I explain to my patients. I can't fix your obstruction. I can just give you more room to breathe. His total lung capacity went from almost 8.8 liters to 5.89. Okay, now looks a little restricted. His residual volume went from 6.1 liters to 2.53. He's had an 89%. Sorry, it's now 89% of predicted. His RV-TLC is now normal for him. He no longer really air traps. And notice that there was almost, sorry, this 50% I think is wrong. There's almost no difference in his absolute numeric diffusing capacity. I think I had that one a little off. I apologize. So in summary, lung volume reduction is a safe, efficacious option for appropriately selected patients with emphysema on maximal medical therapy. It really does require an intact fissure, and I think Chartis assessment is important. If you had Chartis, I think you could use both valves. It wouldn't matter, and there may be reasons to have both valves for sizing reasons. I know Dr. Kreiner, who's done the majority, or I should say the most experience in the country, has patients who has both vendors' valves in. For collapsed ventilation positive patients, surgical lung volume reduction does remain an option for patients who have asymmetric, primarily upper lobe emphysema and low exercise capacity, but this is at the risk of higher morbidity and mortality. Pulmonary rehab. So I don't have any data on this because we don't have any data on this, but what I'm going to tell you is LVR and rehab are a marriage made in heaven. So I can fix your inspiratory capacity, but I can't get you to then enjoy the benefit unless you go through pulmonary rehab and recondition. So 100% of my patients post LVR, they all go to pulmonary rehab. In fact, as part of the deal ahead of time, if they won't commit, then I have a conversation with them about not doing it. And with that, I will shut my screen down and I will, let's see, can I stop sharing? How do I stop sharing?
You already did.
Oh, good. I was going to say, can you take that away from me?
Yeah. Yep. You're good. You're good. Thank you so much.
Right.
That was great.
It is a pleasure. And I'm happy to take any questions. This is a topic that's near it. Yep, sorry, I'm looking at you, and here, I can fix this. My camera is mounted on top of one of my two screens, so I have a tendency to look in the wrong direction.
That's okay. Did anyone have any questions?
Now, there are some off-label indications, or sorry, there's some off-label use, okay? Right now, Spiration, their valves do have a compassionate exemption for the management of bronchopleural fistulas for non-surgical patients, okay? We're actually looking, right now we have a patient with COVID who has a pneumothorax bronchopleural fistula, luckily a small leak, but if it starts to get worse, we would consider, putting valves. If we can trace the leak, we'll put valves in and try and close it. If you are doing bronchoscopic lung volume reduction and you have valves in your own personal stock, so the requirement is you have 2 patients of stock available, then you can use it off-label. So most places that are doing LVR with the Zephyr valve will just use the Zephyr valves off-label for management of bronchopleural fistulas. We are not doing that yet, so we went back to Spiration and talked to them. So I personally have done about 30. To get to that 30 patients completed, I have evaluated well north of 100. Okay, so a lot of patients are inappropriate for a variety of different reasons. My favorite reason is the patient comes in, they're on inadequate regimen. You actually put them on an adequate regimen. And I know we're not supposed to talk about asthma COPD overlap syndrome. They kind of took that away. But I've seen a couple people have profound responses to triple therapy, and suddenly their PFTs no longer meet criteria. More importantly, the patient feels better. So it really is important to pick these people carefully. The other thing is your institution has to be, if you're going to do LVR, your institution has to be able to have 24-hour coverage for managing pneumothoraces. It can't be somebody on call coming in. You have to have somebody in-house who can respond appropriately. And that may be look at an x-ray, get some more x-rays down the road to put in an emergency tube in the middle of the night. The last thing is for patients who also are young enough to meet criteria for lung transplant. I personally won't offer the valve. I actually send those patients off for transplant evaluation. If the transplant center wants to do it as a bridge to transplant, it needs to be done through that transplant center, so that you're not committing the patient to something that then would prevent them from having a lung transplant. So for those people, I do tell them, look, you're going to go down there, you're going to get evaluated. If you wind up with valves for them and there's a problem, look, I can manage your complications locally. And if you decide not to do transplant, I'm happy then to take you down the road of LVR, but I'm not going to do that until you've seen that transplant program. And so it's actually crazy doing LVR. Is in the last year, I have referred out on first visit 2 patients for transplant when I met them. And I now have up here, I have 2 patients who actually are young enough that they should go get a transplant valve. So I'm sending, well, one's got to quit smoking, but the hard thing. But, I have 2 patients here who both meet criteria for transplant valve. So.
Wow, that's very cool. How often do you do the Chartis afterwards? I mean, do you do it right after, or how often are you doing the follow-up?
Oh, so we don't actually go back and redo Chartis. So basically at day 45, everybody's supposed to get a CAT scan. It is a high resolution at full inspiration, and we send that off for the StratX evaluation.
That's what I meant.
But here's the kicker. So patients will migrate valves. I did not present the one who was in the shower. All right, we had full lobar collapse. The guy's doing fine, and he's in the shower, coughs, and suddenly can't breathe. And it wasn't a pulmonary embolism. He migrated a valve, the lobe popped open, and he goes from having improved pulmonary mechanics back to having acute emphysema. And it was amazing how much he couldn't breathe. So in a case like that, even though I can see that the lung reinflated with the X-ray, I always get the CAT scan. It's unfortunate I have to make them wait for the StratX reevaluation, because it can be anything from granulation tissue causing the valve to unseat to the valve actually being expectorated. And so I want to know what I'm really dealing with before I have to go in and try and find it. Okay, so everybody gets a StratX post, and if there's any change, they get a StratX post.
Well, thank you again. We really appreciate you coming and talking to us about this.
Oh, it's a pleasure. It's a pleasure. I've got right now, I've been a month here, and we have about 6 patients undergoing evaluation right now, and that's just the ones that walked into the office. So I think there's a tremendous need here, and this really is the biggest benefit is, or the biggest kick for me is, I'm changing a life. They get better. Okay. And with that, thank you very much for having me.
Thank you. Have a great day.
Yeah.
All right.